I'm told it's 10:05, so we have to start. All right, this morning we're going to, this is part 2 of yesterday's intro to vaccines, where we configured and added to inventory, and now we're going to administer and go through the reconciling and everything in between. So let's get started. All right, today's session goals. We want to make sure you know how to accurately record your vaccines, report on your vaccines, and we're going to show you our best practice workflows that we teach all clients coming into PCC. All right, the first step is giving the shot. Okay, so for 4 items that we want to make sure you're completing. We want to make sure you're reviewing the patient's immunization record. So when you have your visit pulled up and you're looking at your immunization component, you should be able to see your patient's history there with all of the dates. And part of that is reviewing just to see if they've refused any vaccines, if there's been any contraindications. You can see that in red, and you can see other things. So we're gonna look at that screen in just a minute. Then we are also going to review our forecasting. So we'll see how to look at the recommended forecasting results based on the new ICE third party that we're using, which is providing more accurate results and forecasting results than our previous vendor. We're going to check the VFC status to make sure that's going to go over correctly to the registry. And then we're going to order and administer our vaccines. Okay, so the first step, we're going to review the immunization record. So you're in your visit, you're looking at the immunization component. So here I can see they've refused the flu vaccine, all in caps in red on that date. I can see a contraindication under the HIB entry there, also in red. I can also see that IPV has been ordered but not administered because there's no date there. So we can see that's out there, ordered and pending. And then finally, we can see that they had measles on 10/17/16. So it's going to provide you that diagnosis or problem list with the vaccine preventable disease that they've had. And some of this is probably a huge review for you guys, but all right. So reviewing the forecasting recommendations. So here we have the third party, ICE, is now providing these results. I believe this is a prior screenshot before we got ICE, so it's ImmuCast. But so it's more accurate forecasting results. And so you're going to look and see the next expected dose. You're going to see recommended dates based on the patient age of that date or on that date. And you're going to see minimum and maximum dates and past due dates. So the green is going to indicate that they're ready to receive that vaccine. I don't have a green example up here because they're not ready for anything right now. And you'll see the past due in red there. So one note I will make about forecasting recommendations. It's not foolproof, as you probably know. It's not intended to replace clinical decision making. So it's just providing recommendations based on no alternate vaccine schedules. It's not looking at conditional vaccines like MenB, for example. It won't show you anything unless they've had their first dose there. So there's a few exceptions, not foolproof, but it's a great tool, and it's more accurate since we switched to the ICE vendor. Okay, so before you administer the vaccine, you're going to want to select your VFC status. Now, if you've been in here before and you've given the patient eligibility status, it should pop in so it remembers their VFC status from before. If it doesn't, you have your drop down here. So immunization registries want to see this status. So regardless of its, whether it's a VFC or not, they want to know if it's not VFC eligible. So you'll want to always fill in that field. Okay, and then we get to the order and administering part. So depending on who's ordering and administering, sometimes your nurse will order and administer at the same time. Sometimes the provider might order it and send it to a nurse or an MA. So whoever's doing this part of it is going to either scan with the barcode scanner. They can go ahead and scan. It'll populate the lot number and dose and the viz information And the VFC should also pop in depending on answer memory and what was there before. You may need to change the Viz addition if it's not the correct one. It will pull in the last one that was used. And you can also manually enter this if you don't have the scanner. Okay, so you will have to mark it as administered. And then you'll need to select the route and site to go over to the registry. And here, if it was something that they refused, you can mark it as such here, and it will show the red refused on the that first screen that we saw before. You can also mark the contraindication here, and you can also cancel it here. So it will strike through the order, and it will not deprecate from inventory if you do that. Yes, question? So for sometimes when you administer a vaccine, the doses don't populate. Are you using a scanner? You're not using a scanner. You may have to select it if it hasn't been selected before. It may, like, answer memory. No. Oh, good point, Jim. Yeah, so we do store dose amounts in the PM side. So maybe it's not entered in that dose field. That's something to look at. Good question. Yes, the question was the dose amount not being in the drop-down or not populating for the administration of the vaccine automatically. Thank you.
How often do...
I'm sorry, I think we just want to make sure that the folks over virtual are hearing the questions, so we're just going to have to run out that red mic for you. Thank you.
How often do the VIS sheets update within that drop down? Like, is it pretty automatic, or with the next software update?
I believe it's updated by the AAP, and we update it once a year, is it? Oh, sorry, CDC.
Instant. Okay.
CDC releases, I don't think you hear me. As soon as the CDC releases the batch file to PCC is when we upload it to you guys. We patch it overnight. So it's random. It's,
Yeah, one other thing I was going to mention too is when we get to that next section under patient education, those are updated automatically too. So if when you're selecting those viz sheets and going out to the patient education tool, those should be automatically updated, those versions. Were you going to say something?
Yeah, I have something to add to that as well. When we say they're automatically updated into your system, that means that they are automatically available for you to select. It does not automatically change the default that's already there. And I wanted to point this out because a lot of people assume it is, so they never change it. So they're like, we got these great new viz sheets, but we're telling the registry that we're giving them the old ones. And it's because they haven't changed the selection. So when there is a enhancement request out there to be able to update the viz sheet selection for certain immunizations when new ones come in, like globally, so that everybody doesn't have to make sure their sticky is set. But I just want to make sure that you guys understood that.
and you get 6 months to do it. So if you're doing a VFC audit, you have 6 months from the publication date to update.
Yeah, remember, your voice does project, but not over the internet.
Little at the top, yeah.
Just a quick question on VISs. What about VISs in other languages?
So in patient education, you do have, I believe there's 2 now. There's Spanish, English. If you go on the CDC's website, I think they're up to 5 right now, and I heard pretty soon it'll be up to 7.
So we use Russian. Is there any way that we can get that in there?
Take a look at cdc.gov.
No. We already use the CDCs,
Oh,
but
okay.
in PCC.
You can get us to upload them to the forms for you. Just send in a ticket to like Rapid Response, and we can, if you have the newest ones, we can add them onto your forms drop down. Okay. Just make sure when we name it, just ask us to name it like TDAP, and then put the date in there so you guys know which one you're using to print.
So to get an understanding, when the physician orders the vaccine, the MA can print the VIS form from PCC Because we've been going to the CDC website.
Yes, I'm actually going to show you in the next bit of slides. There's a patient education tool built into the EHR, and you can actually search for those VIS sheets and print them, or even attach them like to the portal, so the patients and families can get them in the portal as well.
I think what would be a great idea is right there when they order it, they can click print of that particular.
That is an
Vaccine
awesome
to
idea
cut
for
out.
sure. Any other questions now? We can, okay. All right, so that brings me to the patient education tool that we were just talking about. So in patient education tool, which we're going to see on the next screen, you can actually go in and choose your VIS sheet. I don't know, I know there's a question about other languages. There might be a Spanish version, but I think that's it. I don't think there are others in the education tool. So we can locate it, print, or save and send it to the portal for the portal users to grab out there instead of printing in office. So here's how you access patient education. If you haven't done this yet, you can go into the reports menu and select patient education. You do have to be in the chart to do this. Otherwise, it'll be grayed out. You won't be able to get in there. And so I just, I did a search on Viz Sheets, and I pulled up a particular TDAP PDF out there. And so at the bottom right, I don't know if you can see it. You might see it better on the next screen, but you can save this to the visit. You can also print it, and you can also display it in the portal, which I'll show you on the next screen here. So this is your, you've seen this before when you're in your document section, right? So you can click on the display in portal docs, and there's your TDAP vaccine information sheet. So that's a quick way to save paper if you don't want to print it for your patients. Did you have something to add? Oh, I can't read that. Oh, okay. Let's see. Oh, yes, it does say, if you guys can't read that, many information sheets are available in Spanish and other languages, and then there's a website reference. So it's immunize.org
Which is the CDC.
/viz. Yeah. Okay, I think that's it. As far as administering, this is you, Romney, right?
Just me temporarily.
Yes.
This is like a cameo for a second here. Something's supposed to happen with that.
Oh, okay.
I know. I'm like, where's my fancy little button? I'm so excited to show you guys this. Oh, okay, there we go. I had a little animation, you know. I know, it wasn't as exciting as I hoped. I just wanted to mention there's a lot of overlap with a lot of the different teams when it comes to immunizations, because you have, you have your forms printing, you have your forecasting, your clinical decision support, your immunization registries and stuff like that. So I work a bit with the forecasting side of things as well. And just wanted to give you some information. When you download these slides, there's some background information. The immunization calculation engine by HLN. So it's often referred to as ICE or HLN. And it's an aid. And as Jen had mentioned, just to remember that it is an aid. It's there to help, but ultimately, the decisions, will be made by the clinicians. But it is more accurate now that we're with HLN and more helpful. And as we were pointing out earlier, things that are conditionally suggested, like meningococcal B, for example, a lot of people are like, why don't you forecast for meningococcal B? And it is a conditionally recommended immunization. And with HLN, there is more information for conditionally recommended immunizations because meningococcal B is not the only one. And we have some, we're aware of that and looking into incorporating that in the future. Let me see what other things. When they're calculating, just so you know, the forecasting when it's calculating, it's using the date of birth, the CVX code, and it's important to know that it uses the CVX code because when you're ordering immunizations or you're recording immunizations, you just see the immunization name. You do see the CVX code in the vaccine lot manager, sometimes in parentheses, but it does use the CVX code. So if you have the name of the immunization, but the CVX code is not correct. For example, you have your Hib vaccines with maybe 2 vaccine code, CVX codes. You just want to make sure that that they're correct. I'm sure you are all aware of that, but it does impact the forecast. Let's see. Oh, another thing I want to mention is that if you have bidirectional connection to your state registry, they also sometimes return the forecast from their system, and sometimes it doesn't match what you see in the EHR, and that's because they use a different forecasting tool. They'll be very close, but there might be some slight variations. Future development, we have immunization, immunity titers and contraindications. So in the future, we want to be able to, you know how you have, varicella under the has had a thing, and you're like, but why is it forecasting for varicella? I mean, they don't need it. And a lot of people have said, well, can we not have it included in the forecast? We're aware, and down the road, we'll hopefully be able to incorporate that functionality in there. Okay, I will pass this back to you.
I think you're next, Elsa.
No, I am. Oh, thanks. That's why I'm going backwards. Jeez, but we get to see my awesome graphic. That was supposed to be like, the magic ball. Okay, who's that?
I think this is just a summary sheet. Actually, this is just a summary of the best practice that we talked about. So scanning to administer. So you can also manually administer your vaccines, but to avoid any errors in lot numbers or typing, it's always best to use the scanner if you can. You don't have to. It just prevents some of those errors. Selecting the appropriate edition of the viz sheet, selecting the appropriate VFC status, and whether or not you want to send that education. Oh, that's talking about the immunization form. We're going to talk about that a little bit later, but printing out the school form or sending it to the portal, it can show up on the portal as well. So depending on how you give those to your patients, it's convenient to have that available on the portal so they can go grab it as well. All right. I think this is Jim, right? The school form.
We're doing drop the mic up here, right? All right. So, as you know, immunizations / the old name is school form, okay? So we're transitioning now. The printed immunization record, it's different state by state. So if you guys say, hey, my state wants this, but the school nurse wants this, remember, we can do that for you guys, okay? Just send us the PDF that you need, okay? And there's some limitations, but we're getting better and better all the time to make it better, okay? Just remember where it's found, where it's printed. I don't remember what my slides. Hold on a second, guys. Let me see. Nope, I'm still on this one. I just was trying to remember my 2 courses here between. When you guys are printing the IMS record, teach everybody in the office, because you're like, sometimes some of the school forms, you guys will print from the forms tool, but then we need the immunization piece to go from under history and the immunizations that way. What you see in the EHR, this was yesterday, I got cornered after I left by a provider and says, geez, Jim, what I'm seeing in the EHR is what is not printing out on the immunization form. That is very true, because you guys give combination vaccines, you guys give whatever you guys decide to name them, but when it prints out, we'll say COVID. There's a good example. There's 17 different variations. But when you print it out for the school, it prints one COVID line, right? So, but, the provider had a good point yesterday that says, well, it's different. Yes, that's true. And remember with the combos, do you guys have us printed out as a combo, or are you breaking that out? So, and just a key thought, like I like to remind you guys, if we at PCC, you ask us yesterday, you say, hey, I need you to add a new vaccine to TED Table 2 like we've told you to do. We add it, what happens in the EHR? It brings it down to the bottom of the list, so you guys have to go down into your immunizations, you're right, and drag it up so that, so the provider goes, I know they had this, but I can't see it, so just remember that help them help you, it all works. All right. Oh, cool, thanks.
Okay, it's my turn.
Oh, is that your turn now? So, okay.
Now I'm really here. Can you hear me? Yes. Okay, good. All right. Okay, Brian, which way is the proper way to hold this thing so I don't go backwards?
You got it.
All right, thank you. And I have the laser pointer too. This is
bi-directional, but we can't.
well, it's too bi-directional. I don't know which way's up. But I do have the laser pointer, so that's good. I'm here to talk about the registry, and I wanted to highlight some key points I want you guys to be able to take away after this, at least from my piece of this registry piece, which is like when it's working, you don't even notice it. When it's not working, it's troublesome. Okay, so there's a couple of workflow suggestions that might be helpful so that you can understand how the workflow that you have in your office regarding demographics and stuff, how it impacts the records that get sent to the registry. Okay, and that workflow really affects demographics and the immunization order. Okay, there are some reports, in particular, Immunization Administration Details Report, which I hope everybody here has looked at, and if you haven't, check it out. It has expanded its ability. In the previous iteration, you could just see immunizations that were administered. Great, and you could add columns and stuff. Now you can actually see immunizations that were refused or contraindicated. You can make sure that they have their refusal reasons, which if some registries are really particular about that. You can separate your administered immunizations from your historical immunizations, because who cares what the route and site is? If it's a historical record, you don't even know. But you do want to make sure that all the T's are crossed and the I's are dotted on your immunization orders before they get sent to the registry. And then the responses. Not every state, but many of the states, they send back responses that we can put into the immunization registry response viewer. Georgia, I don't think you're one of them. I'm so sorry. I wish you were, because it would solve so much. But most of the states do have responses that help. And some of them, they're very minimal. Some of them will just say, hey, we sent the M. And even though that's not that important, it is important, because when the registry says, well, we didn't get it, you can say, yeah, you did, and you call us and we can give you all the details that you can argue with the registry about. I'm going to show you all these things, and yes, we're going the right direction. So immunization registry workflow. When you have a new patient, and I've discovered this because I'm working in the clinical data exchange world. I'm not generally aware of how people do other things in the EHR, but I had to become aware because I noticed something. Immunizations are going to the registries, and they didn't have like address and phone number. Like, oh, how do you do that? Well, I figured it out. Some offices, they'll add a patient to their system, and then when they come in for the first visit, they'll can finish up the demographics. And that makes sense, because when you're scheduling a patient for a future visit, you've got a lot going on. You're just like, I'm just going to get them plugged in there. We'll worry about the rest later. Between them adding to the HR and their visit, a record comes in and says, oh, here's the immunizations for this patient. They're transferring. Like, great. Plug in those immunizations. Well, as soon as you enter those historical IMs, they're ready to go. Without enough information for the registry to say, who the heck is this? So my strong suggestion is that you make sure before you add any immunizations to make sure that they have a custodial, like a home account, and that home account has an address entered and a phone number entered and a single email in the email field, not a lot of notes. I know most people are good about that nowadays, but when we first added that email field into the accounts system, it is still a free-form field. And so people were like, well, they don't have an email, so I'm just going to write NA, or I'm just going to put a note here. We don't collect emails. Well, now it's more and more of a thing. So just put a single email in there. And then also, most offices now have by default that when you create a new patient in your system, it will use the home account as the first personal contact. And I'll get into that more later. But the personal contact is what is the next of kin that gets sent out. And I think across the board, all the registries require that now. And so that next of kin information is pulled from that personal contact, and you can add more, and we'll send everything that's listed. So if they have multiple personal contacts, that's fine, but you have to have at least one. And so generally by default, we'll try and, there is a setting under practice defaults to use the custodian account for the personal contacts, so make sure that that's set, although I think nowadays that is just the general rule, right? And then after you get all that squared away, then add the immunization history, and that will solve a lot of problems and reduce headaches. Existing patients. So when you have an existing patient and they're coming in, just confirm their demographics, because if they've moved, or if there's any missing demographics or anything, or you're adding more personal contacts, or whatever, just you want to make sure that's all up to date. Since COVID and the requirements from the registries to report to the CDC or the federal government or whoever at the time they need to report to, they required that the registries send race and ethnicity, and the race and that piece was a requirement for, if the registry had that information, they're supposed to then send it along. The registries interpreted that as you must include race and ethnicity, and now they have a very high threshold, and they want it. Some states will even reject the message if it doesn't have race and ethnicity in there. So even though it doesn't seem like it should be a requirement, because it's not a required thing, you don't have to declare anything. Because of that requirement during COVID times, it's now becoming a requirement. So if you have an existing patient in your front desk, if they can put something in there, the states do understand that people will make stuff up if they don't get an answer. And it's helpful to you to know if you've asked already. So you don't keep asking. If somebody says they don't want to answer, then that's fine. So there's options to prefers not to answer, and the states are slowly changing their requirements in the report submission, so that translates into, we tried to ask, but we don't have an answer. And so, and that way you don't have to keep on asking. But as your workflow goes, just make sure the demographics are clear. Race and ethnicity is entered, perhaps preferred a language. I think Connecticut is pretty intense on that. Are you from Connecticut? Connecticut, I could pick on Connecticut. I could pick on Connecticut, but actually the registry is actually pretty tight. So, and Connecticut, are you using the Medicaid number option? If you're not aware, oh good, I was wondering if anybody was using it. Yeah, we added that there, and that was helpful. So if you can't tell, a lot of states have wildly different requirements, and everybody's like, well, why can't you have, why can't we just have a national, registry database? That would make a lot of sense. But then, Texas and North Carolina and Connecticut all have different requirements, and they're not going to ever play nice on how that works. So we got what you got for now. Let's see. When you're querying immunizations from the registry, if you're in a state that we have a bidirectional interface with, obviously it's important to have your demographics updated, make sure that it's all good, because they need to be able to find that patient. And sometimes you'll get responses like too many matches or can't find the patient. And in those cases, there's not enough there's not enough information to find a unique patient, or there's too many patients with the exact, like they might have multiple entries in the registry. And that's the good time to then go into the registry and just compare the demographics you have in the EHR with what's in the registry. And some registries allow you to update it to whatever needs to be, but I'm not sure if all of them do. So, but just to be aware, they're looking at the name, date of birth, and address, I believe, to match that. VFC eligibility. You can add the VFC eligibility for any immunizations ordered that day. You can generally, I think in the previous slide you saw in that field where you can select the immunization, the VFC eligibility. That will then cascade into all the orders for that day. Now, during COVID, you sometimes had an exception where you needed to use a different eligibility status for COVID, and you can actually switch those per immunization. So, but just so you know, it's easy enough just to select it. Some offices, they even want the front desk as they're checking them in to select it. I don't know the details on that because that would require them to start the visit. But however you do it, once that's selected, it'll populate for all the orders in that visit for that day. Okay. What other thing? I feel like I missed something, but I'm sure we'll come back to it. Okay. Let's go here. Okay. So I want to present to you the journey to the IIS. It is a journey. It's really a journey, so it's an actual miracle that all of this works, but I want to show you kind of like a little bit of the process of it, okay? IIS is the Immunization Information Systems. That's kind of what they're kind of translating their names to. Oftentimes, they also refer to themselves as the Immunization Registry, so you've got NCIR, North Carolina Immunization Registry. You have the, I think Colorado Immunization Information Systems, so that'd be CIIS. So it's used interchangeably, but the IIS sounded enough like ISS for the space station. I was like, here we go. So we're going to take you on a journey to the IIS. And it starts by, if we're doing immunizations that we order, because those are the ones that, deduct from our inventory, count on our VFC inventory. If they're not reported, why am I feedback? Oh, yeah, that's probably what it is. No, it's not. Count towards our VFC inventory. And there is another mic, though. Is there another mic floating around here? Okay, they're both off? Oh, that's interesting. Oh, okay. Anyway, you want to make sure everything is, all the T's are crossed and the I's are dotted so that you don't end up, having conversations with the VFC coordinators and who, or whatever, or you have discrepancies in your inventory, because that's where it happens. Something happens. There's a typo somewhere. The lot number has a 0 instead of an O, and then suddenly all this time you're not getting your inventory on the registry deducted. Okay. So once you press that saved changes button, whatever, when you're doing your order, after you've marked it as administered and you put all that stuff there, it's ready to get on the train. It's ready to head out. Now, depending on your particular office and your particular state requirements, it can go out once a day, once a week, twice a month, or every 5 minutes. And that's very specific by state and by office. But it gets queued up and ready to go on the train. And then when it gets sent out in whatever the last status it was sent. So if somebody administers the immunization and they hit save changes and they're like, we'll just update the lot number later or whatever, or we're gonna, we'll put in the site and route later when we have a few minutes. That's fine if you're gonna, if they don't get sent out until the next morning, but if it's gonna get sent out in the next 5 minutes, that's a problem. So just so you know, save changes queues it up, and when it goes out, it'll go out with whatever's there. So queued immunizations, they're batched. Once they're queued, they get batched up, and then they're sent out to the registries. Or actually, they're first sent out to the hub. So everybody here, all your IMs, they come to PCC hub, and then they get sorted out. And my notes, as where did Brian go? Brian, you know how you made them smaller so that they didn't take up all the screen? Now they're teeny tiny. Oh, he pressed this button here. There's the plus button. Oh, yeah, someone pressed. Okay, thank goodness, because I did have some secret notes behind the scenes here. So he got, this is supposed to be chocolate, It's just the factory there. So anyway, yeah. So this is once it's queued, and then it's batched up and sent to the hub, to us. Then we then send on a separate but similar schedule out to the registry. And the convenience of that is that, like if you move offices or your IP address changed or whatever, you don't have to go through all the re-verification process. We have this one hub, and it doesn't change. With the credentialing to connect is all with this one space. So it simplifies things quite a bit. So then the hub sorts things out. You have a question? I have a question. Yeah.
So for Connecticut, we get the immunization response
Yeah.
if we get an error. Once we fix the error, does it automatically get sent to the state?
That's a brilliant question. And I'm not sure if I even covered it in my notes, so thank you for asking. So it's state-specific. Some states will allow you to do updates. Georgia doesn't. I'm not picking on Georgia, I swear to God.
This sore subject for years.
I know. Well, you know, Grits is upgrading to 2.0, and I'm crossing my fingers that that's going to be helpful.
Dreading it, to be honest, but we'll see.
But Connecticut, you can send updated messages. Georgia can't. Texas right now can't. A couple others can or can't. But what that means is if you change anything in the immunization itself, so if you're like, oh, I didn't, put the phone number of the next of kin in there right, that's not going to do anything. But the immunization itself, so you have an issue, you didn't put in the VFC status, or you forgot the route or site, you change that, and it will queue it up to go out with the next batch, and it'll send it as an update. So it'll be like, we've already sent this, but we have some new information. And that's how updates work. If you're in a state that doesn't do updates, unfortunately, you'll correct it in the HR, but you'll have to go into the portal and fix it there as well. Yes, that was another question.
So I know we're able to have our information transfer over every 5 minutes now.
Mm-hmm.
Is 5 minutes the least amount of time that we can do at this point?
Yeah, this time, yes, it is, because it goes from there to the hub, and from the hub every 5 minutes to the registry. And I forgot the reasoning why it was every 5 minutes, but that's as short a time span as it can be.
Okay.
Because you have to then have time for the response to come back and stuff like that. So, oh wait, you have an answer. Yeah, so Alex, I work with Alex all the time. We're like an immunization registry team, and he's the developer that sits quietly behind the scenes, punching all the buttons and making these connections work.
It's not a coincidence I was assigned to this session. So yeah, my name's Alex Whitehouse. I'm an engineer on the clinical data exchange team. The reason why 5 minutes is the lowest limit on sending is because when we're batching this information up, it's a process that can take a certain amount of time depending on how many immunizations there are, how much data inside of each immunization is available to package together. And if we go lower than 5 minutes, then on a computer level, we run into a problem. We can have collisions in data where, for instance, while one IM is being batched up, it's being packaged together, the process fires off again, and the system thinks, oh, this hasn't been sent, picks up that immunization again, and fires it off, and then we're sending the same message twice up to the registry. So yeah, collisions are kind of the reason why that is the lower limit at the moment. Technology may improve in the future on a general level for that to not occur, but yeah, that's the reason at the moment.
Thanks. Right, where was I? So we're talking about updated messages and stuff, and making corrections and things. And one point I want to make on the updates. Let me just make this one quick point. Is that if this also works if you change your lot number. Let's say you had been using a 0 all this time, and actually the lot number is an O. You're like, oh, geez. Well, you can go into that lot and correct that O, and it will cascade updates for all the patients that had been administered that lot. Now, I tell you this, but I also want you to realize that there has been some misunderstandings in the past with some practices early on when they didn't quite understand it, where instead of adding a new lot when they got a new batch, they're like, hey, I got this immunization here, and we got a new lot, and we're not using this one anymore. We'll just change the lot number and use the new lot number. Now that you know what I'm talking about, can you imagine what happened? All those patients got resent with a new lot that they didn't get. So, yes, I don't mean to scare you, because I don't think if this happened, you would know it, because we would have talked to you. It's very rare, but just so you know the impact of that. So if you make changes to the lot, it cascades to all the patients. So that allows you to correct things, but it is just for that lot. Okay. You had a question back there, yeah?
We have a question from the virtual chat. Know that you touched on this earlier. Sorry if I missed it. Is there a way through PCC to report that a patient has had varicella, or would I do this through the registry directly? I'm in California, if that makes a difference.
That's the simple question is there is a way if California's format allows it. So if they are like, yeah, you send us this, then yes, we can send it. If California's like, we don't do anything with that information, then no. Even if we did send it, they couldn't do anything with it. I'd have to look into it to find out specifically for California, but there is a way, and there's a setting in the immunization config that if you all haven't fooled around in that, which I recommend you do, and by fool around I mean just look at it, and it's not, it's for you. So there's two or three tabs, and one of the tabs just has the list of immunizations with check marks. Those check marks are checked on immunizations that are going to show up by default whether or not the patient has received that immunization. So if any of you have a patient's chart that's got a scrolling mad list of immunizations that they've not received, and you're like, why are they showing up? They haven't received the immunization. It's because they have the check mark next to the name in the immunization config that says show it all the time. If it's unselected, then they won't show unless they have an immunization. That was been a slight misunderstanding, I think, in some practices. If it's not checked, it won't show at all. No, it will always show if they have an immunization. So if you want to shrink that list to not have a lot of blanks, you can just modify that. The other thing is, the other tab is immunizations and diseases. There's a series of check boxes there, and one of them is if they've if they've had the disease, do you want it sent to the registry? Now, I think by default they're selected, but if it's not, you can double check. So those check boxes you can select to say, yeah, I want this disease to be sent to the registry. And so if it's on the problem list as like had varicella or had measles or whatever, it'll get sent to the registry. Anybody else have any questions on that? No.
Not really a question on that, but if our
Sorry. Wait.
So our state just recently went bi-directional.
Mm-hmm.
We've been using the sending info for forever, but it just went bi-directional like within the last couple of months.
Mm-hmm.
I know that in order for us to go bi-directional, you guys have to do some settings. Does that change the workflow between what we're doing now and when those settings are turned on?
No, although I will say it's kind of interesting that once you have bidirectional, you can query for their IMs before even seeing them, and that also kind of is a way, depending on your state, to see whether or not you have your demographics all set up, because nothing's going to come up if it's not there. And in the way it would change your workflow is it allows you to, like, for instance, if you're in a place where a lot of their flu vaccines are administered at the pharmacy or whatever, and you're trying to make sure you got all that in there, flu season comes along, yeah, hit that query button all the time just to make sure you got that all in your system.
And so I guess my follow-up question to that is, so we see a lot of Hispanic patients that have double last names, and unfortunately that always really confuses the immunization registry. Many of them have more than one entry, one with maybe just one half of the last name, one with both. Is there anything that we can do or anything that PCC can do to make that not be a huge mess?
Yeah, I mean, honestly, it's whatever you have in the HR for them gets sent over for demographics matching. And if there's duplicates in the registry system, that has to be sorted out on the registry. So if you are having issues, going into the registry and cleaning up their records there is the only means of fixing that.
Hi.
The only other thing, real quick, I wanted to follow up, and also is if you're giving Prevnar 20 and they transfer to you and they got Prevnar 15 from the different doctor, let PCC support know that we need to add that for you, because we will add that to the table in the background. That's the only other
Oh, yeah.
stopping point
I
with
actually am going to
bi-direction.
cover some
Oh,
of that
are you?
there, yeah,
Sorry.
yeah. No, it's
Okay.
okay, it's okay. It's okay. And you had a question? Oh, right, and we had, sorry. Oh, gosh, yeah. I knew somebody out here did.
I just wanted to go back to the vaccine configuration. You were talking about the checked and unchecked vaccines showing up. Is that specific to a patient, or is that overall?
Overall, so once you sort out what you want visible by default in the chart, with or without a date, make a check mark there, but then everything else will not be visible unless they have that.
And that's for the when you print out from the for the
now
patient.
printing out is different. That's very different. That's the school form, the form that basically puts dates by diseases that have been immunized by, for, versus, well, even the patient history or the visit summary will have like a list of immunizations, but that's the immunizations themselves. So you have your immunizations, Penticell, and you have the diseases Penticell vaccinated against, your DTaP, IPV, and Hib. The nurses, they don't like, sometimes they're like, what's Penticell? And school nurses, not the, but whatever. The administration is like, we don't know the fancy name for whatever this is. We want to know what disease they've been, immunized for. So that's what that school form's for, is to break it down so that somebody knows what they've been immunized for. But you and everybody else wants to know how they got that, and that's the vaccines. So that's why there's two separate things. Now in this patient summary, it does list the actual vaccines they got administered, but the school form is much more configurable by disease. Yeah.
One more. Oh.
Well, I have a question with when you were talking about with if your lot number is not correct, you correct it and then it sends it again.
Mm-hmm.
I know when you scan them in, it's correct in your
Yeah, if you use a
vaccine
scanner,
lot, it's there.
that'll reduce a lot of trouble.
For our state vaccines, they're automatically put in by the state for
They're-
whatever is sent to them. I mean, as far as with your lot numbers, they're automatically put in by the state. But private, we have to manually put in. So if I make that O a 0 when I'm privately putting in the private, but in PCC it's the O like it's supposed to be, so then it kicks that back, that
Well-
it's not a correct lot number?
So when you're talking about when the state puts some things in, they're putting it, you're managing inventory on with the registry. And the state will for your state, update your inventory for VFCMs. And then they leave it up to you to manage whatever you want to do with your private Ms. Some states will also allow you to manage your inventory, Georgia, for private pay, which is handy if you want to do that. It's terribly not helpful if you don't want to do it and you think you aren't, but they have the switch turned on that you are, and that causes some havoc. So for private, it does matter that you put in the right lot number, regardless, because even if you put it into the registry, if for whatever reason there was a bad lot and they're like, we need to contact all these people because this lot was not good, or whatever, we need to contact all these patients. Well, it requires you to have a correct lot number, regardless of whether it's VFC or not. I mean, that's a real edge case. I don't know when that's happened, but it is important to have the right lot number. But for inventory for VFC, it's essential, because they will not deduct it if the lot number is incorrect.
Right. But if it's correct in PCC,
Uh-huh.
because I did the O instead of a 0,
Yeah.
no, I scanned it and it was correct in PCC, but when I manually put that inventory, private inventory, into the NCIR,
Mm-hmm.
instead of making it an O, I made it a 0.
Mm-hmm.
When it sends it over,
Mm-hmm.
will it detect is it going to send it back that lot number is not available in the NCIR?
Depending on how NCIR does stuff. So if you're managing your private lots in NCIR, then it'll say, hey, we don't know that lot.
We don't have that one.
Yeah, and then you'll have to manually fix it, and it won't go back and be like, okay, yeah, you did send those. No, that's a bit messy. So you want to make sure that the lots that are entered in the registry inventory system is the same exactly as you have in the EHR. That's the only way it works. And yes, but some like I said, some registries, if it doesn't match, it may even reject it Sometimes it just simply doesn't deduct it, which for private is, you know, whatever, it's your private stock. For VFC, it's really, really, really matters. So, any more questions here? You have a question?
So when entering historical data into the immunizations, we often encounter the issue where if somebody comes from another country, MMR is given separately as measles, mumps, and rubella, and often not on the same day. So when we enter that into the system, although the child may be up to date on that vaccine, when it goes into the registry, it just confuses the heck out of everybody. It doesn't go into the MMR because wasn't given as an MMR. Any recommendations on what to do in cases like that?
Right. Well, are you entering that historical immunization in their separate components?
Yes.
Okay.
But in PCC, not in the registry.
And then when it gets sent to the registry, it goes in with their separate immunizations, as they should. Then the registry does what they will with it. I mean, honestly, the registries don't take everything. Was it, I think Synergis, or like they bounce that out. And it's like, but we gave it, and the registry's like, I don't care. Of course, you want to know that this kid's been vaccinated against MMR, even if they did it separately, and that happens. And I feel like it's happening again because of the measles outbreaks and stuff. But so you're doing what you need to do. You're not going to make up like, oh, the kid got an MMR just so it'll show up in the registry. That's not correct. So yeah, just keep doing what you're doing on that. Any other questions on those topics? I might be covering some more. I'm like totally taking over the slides. I also have more pictures to show you. Hopefully they're not too scary. I was really going into the very like cyberpunk library Pony Express land. So, so we get the immunizations from everybody, from all our clients, and then we sort them out like it's the post office, really. And the facility IDs, they may be called, you know, practice IDs, provider. Texas calls it Texas IIS ID, but they used to call the PFS number. There's a number, and it's designated to your physical location or your sort of physical location. I mean, if you move a couple blocks down the road, you still have the same PFS number. But if you're a practice that has multiple offices, each one will need its own identification. So, and back in the old days, you could just be like, we're one happy practice. We may have 10 buildings, but we're all this one place. Nah, not so much anymore. So we generically call it the facility ID. And some states, they have like, everybody has a facility ID, and it's great, and they want one overall ID for the practice. And sometimes they even assign a separate overall ID for the whole practice. But some states are like, no, we'll have a parent ID. So it's the same ID, but they'll be considered a parent. Now, you may not have any hierarchical structure in your practice for all the different locations, but you may be asked to say who's going to be the parent facility, because historical immunizations go out under the parent ID, because nobody in the practice administered those, but you're reporting them so that the registry knows about them. And if they already have it in the registry will say, hey, we already got this. It's okay. We're good. So I just want to make you sure that you know that. And so that's part of the sorting process as well. So we get it, we transform the messages in the background additionally, just so that they can go out in a way that the registries will respond to it. And because you'd think they'd have standards, but not so much. We set up them for standards, and then we have to transfer them a little bit further. So when we send those out, we look for errors. They're not errors in whether you forgot to put in the VSC status. They're errors like, hey, the registry took a nap and bounced all the messages, and we need to resend them. So we can often catch those errors, and we'll resubmit them. And you know, when you probably get some emails from your different state registries saying, hey, we're going to be down for maintenance, you know, we also get those emails, but also our system will be like, hey, we're trying to send something. Oh, you're closed for the afternoon. Okay, we'll try back later. So sometimes if it's bigger, we'll know about it, and we'll actually have to manually trigger those to go off. But just so you know that those types of errors are transmission errors, and when we are aware of them, we'll see those errors and resubmit them. I forgot I wanted to mention this, the HIEs. So some states, time to pick on Michigan. Anybody from Michigan? No. Oh, I can talk about Michigan all day. No, I'm just kidding. But it's not just Michigan. It's my own home state, Vermont, too, and other states. Instead of going straight to the registry, they go to the Health Information Exchange, whatever they may call it in whatever state you're in which case it goes from our hub to the Health Exchange, and then the Health Exchange is like, well, we'll do something with this maybe, and they may have transmission errors. And so as you can see, sometimes it can turn into this pachinko machine of like, I hope the M gets there, I hope the M gets there. But it does have to go through many vendors in some states, but not all states. And so if you're in one of those states, you know it, and sometimes onboarding can be a challenge, or troubleshooting, because you're like, hey, my record didn't get over there. You guys call us because we answer the phones, and and we're like, yeah, we sent it, and then we call the registry, and the registry's like, we didn't get anything. So then we're like, well, we call the HIE, and we're like, huh? Oh yeah, we forgot to turn it on again. So just so you know that there is a lot of places this little record goes through, and So, like I told you, this is a journey. So the IAS, when they eventually get it, they process these messages, and they add the records to the patients that are listed in the registry. And sometimes, in some states and some practices, these patients are kind of like assigned to the practice. So sometimes they can even be specific to your patients. But they know all about that. And so they use your facility ID, they use the patient's ID, they use the sender if everything's okay, and they use the sender, and they're like, hey, this is this patient here, and they update the record. Did you have a question out in the back here? Oh, okay. So anyway, so they'll update the records listed in the registry if they can find the match, which generally they're pretty good about, and it's helpful to have complete demographics. That really helps the match. And twins. I don't know if I mentioned this in the previous slide or the next slides. Am I running out of time, by the way? Because I can talk all day about. Okay, I'll try to speed up. But the more accurate demographics you have, the better the match. Twins. Why do people name their kids the same name practically? And it drives the insurance companies crazy.
We literally had a set of twins with the same name.
Oh.
That just came in. There was a 5 and a 6.
Oh my gosh.
The 5th and the 6th. We have that too. Quite a few of them.
Oh my goodness.
It's nuts.
That damn George Foreman.
I know. So, there's that multi-birth indicator, right? Well, in addition to that, what people don't notice is that right next to there is a drop-down. Please use that drop-down, because if you indicate they're part of a multiple birth, the registry's going to be like, well, is it the first one, the second one, the 5th one? Don't forget that. I mean, maybe you don't know at the time. I mean, who knows? But if you can get that, please indicate their birth order. That is super helpful for those twins. Poor kids. Oh my. All right. So the messages get processed, they get updated in the registry. And then the registry sends back we have received your message, and here's our response. And they'll tell you all the reasons why they're not going to update that record. Or hopefully they'll say, yeah, we got it. It's great. Thank you for sending it. And you will see that gets sent back. Now, if your system, if your state has an acknowledgement message that actually is a standard and parsable, we'll even include that information in the immunization registry response viewer tool. Boy, that is a mouthful. We'll include that, and you can see exactly what they accepted or why they rejected it. Unfortunately, they're not very clear on, they get into a lot of like, well, your RxA 18 is missing a something, 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 and I'll get into that in a second. They shouldn't expect you to be able to read that HL7 messaging stuff, but they do send that back, and so people often have questions. I'll try and help you out with that. So they send back the message with any errors or warnings. Warnings are like, yeah, we really wish you did select that multiple birth order, but you didn't, but we'll still record the immunization in the registry. Or you didn't even have a address and we're just like sending this back to you, or you didn't put something in there and we're rejecting the message. So this is what the immunization registry response viewer looks like, and there's a bunch of cool stuff that it can display. So you've got you probably can't see it from way back there, but there's a bunch of filters and stuff. You can filter, if you're part of a care center, you can filter by care centers. You can filter by response severity, warnings, errors, all severities or none. You can actually narrow it down by dates if you want. And then you have reviewed by statuses. You probably can see these little check marks here, right? These check marks do nothing for the records. They're for you. So if you are the office that goes through this thing and you don't want to like repeat yourself, you can mark it as, yep, we reviewed this. We fixed it if we can send updates, and we're going to mark it as reviewed. Puts a little check mark there, and then you can, if you're going back here, just change the filter to say only things that aren't reviewed, and that makes your list smaller. So if you're the kind of person that likes to check lists and make them go away, that tool's for you. All right, next, decoding. Okay, so HL7, what the heck is that? You know what? You don't need to really know, but you're going to have to, because that's this language they speak if you're looking at things. So I've given you a cheat sheet. If you download these slides, that might be helpful. So you have a message that's broken out into segments, and you have your message header that says, hey, here's a message that's coming from this place, and we're these people, and we sent it at this time, and yada, yada, yada. And then you have another segment that's, hey, in this practice, and then another segment says, hey, I ordered this thing, and I'm from this place. And then you have the immunization that was ordered. So it kind of like goes down. Also information about the patient. So you have 3-letter segments. Well, NK1 is a number, but you know what I mean, 3 character segments. And they're the pieces that hold these information. So this cheat sheet, when you download the PDF, will have this. So you have your PID segment. That's all about the patient name, the address, which comes from the custodial account, the phone number, the email, if you have that in the custodial account's email, stuff like that. The PD1 segment is additional demographics. So for states where you have to opt in or opt out your patients, anybody here from Texas? We do not put crazy Texas codes in PD1, but we will talk about that if you have questions. Not to pick on Texas too much, but everybody in Texas struggles with that. Yes, you have a question over here.
So we're taking a look at their immunization registry response viewer, and they have their date range set for the last year, and we're seing no responses. Is that typical?
Are they from Texas? Yeah. Texas and Grits, they can get together in a support group about that. Yes, if your state, and Texas is also one of them, doesn't send back responses that we can put into the response viewer, unfortunately. Yeah, but I'm glad that you're paying attention to that, because we are actually working with trying to update the interface with Texas. It's a bit of a challenge because of the special requirements that Texas has. And it will require a dedicated person in your office to work with to get through that process. But once it happens, it'll be really good.
I just want to add one quick thing about this slides. I've seen people take pictures of it and writing notes. These concepts are publicly available information. You can very easily Google these to find out what they are. I work with this all the time. Let me tell you, Google is my best friend when it comes to deciphering what these are.
Mm-hmm. Yeah, I kept this short and simple just to make it easy to read, but he's absolutely right. There's a lot of information on these HL7 message segments. For the sake of reading the responses from that viewer, sometimes they'll reference these segments and you're like, what the heck are they talking about? This will break it down. So the NK1 segment is your patient's personal contacts. So all those personal contacts that you have that goes in that NK1 segment. And they now, I think every registry requires at least one personal contact. And then we have our, if you're in Texas, you may see errors for the ORC12, or is it ORC10, or RRC10, whatever, where you have the ordering provider missing, or the NPI number, something weird like that. They're talking about the order, whoever ordered it. RXA, that's all of the immunization information. So it's the date the immunization was administered, the CVX code or the NDC code, or if it was refused, the refusal reason, all the details of the immunization except for the route and site, which is in the RXR segment. And then you have your OBX segment, which has the additional stuff. So your viz sheet information, your funding source, your VFC information, and any contraindicated reasons go in there as well. And then if you're retrieving, if you have the ability to query, retrieving immunizations, actually I'm kind of like shifting gears now. So before I go into this, does anybody have any questions about immunization orders and submitting immunizations to the registry? Yes. One second, let me get that mic over to you real quick.
So we get the data quality reports from the state,
Yeah.
and for some reason, our emails are coming back like 28%.
Yeah.
But for each patient, we have an email because of the portal.
Right, but
So-
that email that they're talking about is the
We-
email in the account.
We put it on their account, so I'm not sure where. If we want to go through later, but
So you put it on their account in their portal,
on the portal, and then we put it in demographics as well.
in the account demographics,
Yes.
the custodial account demographics specifically.
Yes.
Well, let's chat afterwards.
Okay.
And by the way, after lunch, there's going to be the walk-in clinics, the vaccine. So anybody has additional questions they want to chat about, I'll be in there. Yeah. Any other questions? Okay, now we're going to the retrieve immunization records. My little futuristic library here. I really actually want to get a microfiche picture because anybody remembers microfiche? No, maybe not. All right. Yes.
Could you move your mic up to the other shirt?
Oh, yes, flipping around. Yeah. Actually, you know what? This will keep me from gesturing all over the place. Okay, so we have retrieving immunization records. That cute little retrieve IMS button that you may or may not see. If your state does have bidirectional, you should have that button. All right. Key things when you're retrieving immunizations: name, address, date of birth. Those things are good. You'll have a lot more success in finding the patient in the registry. So make sure that that the demographics are up to date. So for your new patients, those are the guys that you're definitely going to be retrieving IMS for because you want to import all those, and they definitely won't find anybody if the demographics isn't up to date. So when you're retrieving IMS, the first thing you're going to see is when they can find the patient. We'll have the patient's demographics and it'll more or less match, hopefully more and not less, the demographics you have. And then the next screen is going to show you the immunizations that are in the registry that you do not have in your system, and those will be in orange. If you do have it in your system, it'll be in black. Now that's super simplified because sometimes you may have, added an unspecified influenza record, right? But the registry is sending you back the very specified immunization record that somebody else administered. Well, it's going to say you don't have that information in there, and you're like, but wait, I do. Well, you have a historical version, so you can clean up the record if you see duplicates like that, and keep the most specified version if that happens. And then, as I mentioned earlier during the forecasting piece, the forecasting results here, that's coming from the state. And so sometimes you'll have the state sending forecasting in addition to the responses. And they should match mostly. And there might be some slight variation depending on what engine the state uses. All right, so once you decide you're going to import these things, you may see some options. So sometimes you might have a drop-down. That means that you have several entries in your system with the same CVX code because it does the match by CVX code. Whatever you name it, it does it by the CVX code. So if you accidentally named, you know, you gave the TDAP with a CVX code of IPV, suddenly you'll see IPV there and you'll be like, what? Well, you wouldn't do that. But what I'm saying is it doesn't care what you call it. Just uses the CVX code. If you have more than one, which some systems do, because they'll have separate entries for VFC versus non-VFC, especially back in the day before we did the funding source linking in the lots, you know, you can have some options to select there. And you just select the one you want it to link to, and it'll link it to that. Now, in other cases, you only have one entry. So it's just as like, do you want to enter it in as, you know, do you want it to come in as Prevnar 13 in this scenario? And in other cases, you'll see something grayed out. When you see something grayed out, and you're like, wow, I really want to import that into my system, call us. Because the reason why it's grayed out is because you don't have a single entry in your system that has the CVX code that the registry is sending to you. And we'll need to add that. And we want to add that because that table is a very, very delicate thing. And when we add that, we also in the background want to update the files that are used to configure the school forms that you send to the schools or to the parents. What? IMS records. I know, I'm so old school. It's terrible. But yeah, so if you see that and you want to import it, please give us a call. We can get that configured. Now, it does tell you the CVX code that the registry is trying to send to you, so that's helpful information. And so when you contact us, tell us the immunization you see here, the patient that you're trying to import it in, and we can get that squared away for you. Any questions so far? Okay. And then in the summary, the best practices for retrieving IMS with the registry. Use CVX codes that match the immunizations being administered. You know, like TDAP could be 106 or 120. You know, you got your Daptocil or your Inferix, right? Everybody's like, well, it's just TDAP, and we've always given the same thing. But it really does matter which one you're using. NDC codes in your lot manager, they can actually help you confirm that you have the right manufacturer and CVX code match, because that's like this triangular thing where the MVX code, which is the manufacturer code, the CVX code, and the NDX code and the NDC code, you can only have one kind of link up of that. So if you know the NDC code and you link it up, it's going to be like, oh, then it's this manufacturer and this CVX code. Well, except for when you're selecting your immunizations in your lot manager, you're actually working with a specific immunization. So for people that are like, I don't know which manufacturer code to use. Well, if you know the NDC code, because you see it on the vial, select the NDC code, and then it will populate the manufacturer. Also, vice versa, if you think you know the manufacturer and you select the manufacturer, then your NDC code selection list will be very small, because it's only going to show you the ones associated with the manufacturer, and you're like, well, my NDC code isn't here. That's either because the CDC hasn't been updated, which is very recently happening for one of the IMS, I can't remember, the new influenza, the CDC hasn't updated that yet. Or you have the wrong manufacturer code listed. So just that's a helpful hint there. Even if your registry doesn't require you submitting NDC codes, because some do, that NDC code trick is helpful to make sure you got the right combo. Having the patient demographics complete before adding immunizations to the chart, that's historical or administered. Know your state-specific immunization reporting requirements, VFC eligibility, funding source, opt-in, opt-out. We may know, but you should know, because you work with them. So if you get any emails saying, hey, we've changed our funding sources for some of these immunizations, like those emails came like gangbusters, different for every state during COVID. They don't make it super available on the website. So I'll be searching all over, and I'll end up like calling Joe Schmo at the registry if I can get a hold of them, and be like, what eligibilities, are you guys wanting today? But you guys definitely should know that. So please please try, we can help you with that, but we're not the ultimate source of that information. And our ability to get that information is sometimes even less than your ability to get that information. So we can give you the options to select it, but we can't tell you what to select. Opting in and opting out. Some states, New Hampshire, for example, is one of those states where if they don't want to share with registry, then they don't even want the immunization. Whereas other states, they want you to know which patient's records they can return in a query. So you say they don't want to share with the registry. Well, the record still has to go to the registry because of requirements of VFC or whatever. But then if you were to query that patient, the registry, if they said, no, we don't want to share, the registry can't share that information. And so that share with registry option is specific to the state. It'll send a specific code to the state, but it does different things. You should be aware of whether your state, even uses it. Some states don't even use it. They're just like, send us everything. We don't care if they care. It's just, here we go. But know what your state wants. And then reviewing the reports. And I mentioned the Immunization Registry Response Viewer, if you have that available from your state registry. And the Immunization Administration Details Report, which now has some wonderful options. I've recently helped an office set up 3 versions of that, one that showed refusals and contraindications with their reasons so they could catch entries where people didn't include that information, one that just showed immunizations that were administered so they could verify that the routes and lots and sites and all that were entered, and one that just had historical immunization so they could make sure that race and ethnicity was at least captured and stuff like that. So use those reports. Know when your batches go out so that you can time it. You can make sure that you can maybe run those reports to make sure that when those limbs get sent, they are as clean and clear as possible. And that's that. When you download these slides, I have these links. You can cross-reference your vaccine names, product name by CVX code. If you go to that link there on the CDC, look up the product name, and it will give you the manufacturer and the CVX code as well. So that's a super helpful resource. There's a couple of Learn articles that are out there for figuring out your MVX codes and your CVX codes in the EHR, managing vaccine lots, reviewing responses, and retrieving IMs. So a lot of this information, more detailed information on those specific tools are links to that are here. And I am finally over. Thank you for your time, everybody. And if you have any more questions, there's going to be the walk-in clinic after lunch. Then we can chat. Okay, and I'm tangled up. I'm going to turn this off so I don't make a bunch of rustling sound. Are you next, Brian?
All right, my slides are much shorter. I have 2, so we'll get through this pretty quick. So really, what I want to focus on specifically today is just the charge posting aspect of your IMS and just making sure that you're having this information going out, and then some of the caveats that come along with that depending on your situation. I know billing Medicaid makes things a little bit different. So things just to make sure. During the charge posting process, we talked briefly at the 101 session yesterday about this, but usually in your configuration for billing, you're going to have a Z23 on each individual vaccine. This is how it will come across in your charge posting screen. You can deselect those and just include one of them on the claim. That's just fine, but we have that and we recommend that. So in case you have one vaccine that's given and then the other is refused, or you're only giving one vaccine, you want to make sure that all of them are set up so that you always have that Z23 that gets included. One thing as well is just checking for modifiers. You want to make sure that depending on your state and depending on how that goes out, some VFC vaccines require an SL modifier. So if you are billing out with a VFC and you're picking that lot, make sure that when you go over to the charge posting side, or make sure your billers are aware that they're verifying that that patient's status matches up with the modifiers that need to go out on that claim. Also, double check on your counseling. Make sure that if you did have counseling with those, and I would say that the vast majority of our practices do for most of the vaccines. For flu, that may be different because you're doing a clinic and it's just quick in and out. But for your traditional, your MMRs, et cetera, those are ones that you most likely are doing your counseling. So make sure that you have the 904-6 series of codes on there. One thing to note as well, especially if you're a newer practice and you're getting stuff set up, make sure that when you have done your configuration that you have verified your 90461 pricing. We have come across it a few times where practices didn't have that at the level that they wanted, or they didn't realize that they weren't charging enough for it. And so those go out, the insurance carriers say, ooh, great, that's little. And then they pay them not really what they should be paid for those. Another question that we get asked a lot is, why do my VFC vaccines have a penny charge? That is from some limitations that we had with some payers in the past, and some may still have that. Why we have that on there is, so sending those out, some payers would not allow any claims that came in or charges that came in if they didn't have an actual charge. So like, well, we're not asking for any money for this, so they wouldn't even accept that portion into their adjudication system. You would send along your administrations, and then they would kick back a rejection and say, hey, we have administrations with no vaccines because you sent over and it was a VFC vaccine and it was $0 charge, and it went over and they're like, well, we're not going to pay you for the administration because we don't see vaccines here. So it doesn't make sense, we're not paying you. So that's why we have that. Now, a lot of systems have been getting updated where they are now allowing, for vaccines especially, those $0 charges to go through. We've also unfortunately seen that some practices have started getting takebacks issued for those pennies on all of those vaccines, saying, well, we shouldn't have paid you that penny on these hundreds of vaccines over the last year, which is really frustrating because that was an effort to make sure it got to them, and they were paying it instead of writing it off. What do you do regarding this? The big thing is, please reach out to us. If you've gotten a takeback from a payer for a vaccine that you sent out with a penny, please let us know. We can make a few configuration changes in the background and make sure that that payer, like when you're sending out to that payer group, that allows the $0 charges out of the system. By default, we do not allow $0 charges out of our system. It's a really quick switch that we can make, but if you are getting those, please let us know, and we can make those changes so that you don't run into that issue in the future. On the aspect of coding, your 90460s versus your 90471s. I said before, your counseling is your 90460s. That is going to be coded with each vaccine. Your 90471s is without counseling, and that's going to be for the first vaccine only. So the big difference between those is your 4.6 series are going to be per component, and the 904.7 series are going to be vaccine-based, just the actual vaccine itself. So looking at the 90461 versus the 90472, you're going to use one 90461 for each additional component for those vaccines. So I have a couple examples. It's a little bit small here, but you can see if you download the slides. Looking at the comparison between an MMRV and an MMR plus varicella. For an MMRV, it would be a single 90461 and then an additional 90461 times 3, because you have 3 additional components towards that one actual injection that the patient has gotten. If you're looking at an MMR and a varicella, the example for that would be a 90460 times 2, because you've given 2 distinct vaccines, and then you would have 2 90461s because those are the 2 additional components that you have on the MMR. Comparing that to a 90472, you would only have 1 additional. So let's say you gave an MMR and a varicella, you would have a 90471 times 1 and a 90472 times 1 as well for those 2 distinct vaccines. And of course, if it was just an MMR, you would only have that 90471. One thing that is the big caveat with this that we have been getting a lot more reports of, and unfortunately we don't really have a good way to fix this other than try to negotiate the best you can, is some Medicaid payers and managed Medicaids have decided that they are not going to be paying the 90460s, which is a really big hit on what you should be making for those and make sure you can cover the cost of the vaccines. A lot of providers, a lot of pediatricians in general, recommend for most vaccines, if you have a combo, it's easier, it's less shots for the child to get. It makes more sense oftentimes to have a combination for that. But The downside for that is if they're not being compensated for that and they're not able to cover their vaccine costs for it because of the lack of payment for the 9046 that can be an issue. Unfortunately, we don't have a clean way to do it. It just comes down to a contract discussion with your payers, and really either that or making the switch, just giving, for you, if you can cover the cost of switching to individual vaccines when they're combos, which again is not necessarily ideal, but something to note. And I will put one little additional caveat with MMR and varicella. I believe that this has been resolved, but I like to bring it up when I can. Please let us know if your payers are combining your MMR and your varicellas. There was a batch of that a few months ago, or almost maybe a year. But anyway, you were sending out MMRs and varicellas. That is a recommendation to help avoid febrile seizures. That makes sense. It should be two distinct. You are coding accurately to the work that you're doing. Some payers were coming back and taking those and combining them into a single MMR code that was coming back to your system. So again, on the billing side of that, if you are seeing those codes get combined where they are two distinct vaccines that you're administering, please let us know. We'll look into it from our side, but as a note, that is not correct coding procedure, and they should not be combining that because it is representing a service that you didn't actually provide, and it's changing what you actually did. So just something to keep in mind of note. And I believe I'm on to Jim or Jen.
All right, let's wake up the crowd. Let's pick on Connecticut. The registry has got the best name in pediatrics, CT Whiz, right? I mean, come on. Who doesn't like to talk about whizzing? All right, so reporting for accuracy. Now I'm going to do slides again. All right, so we're just going to do just a quick deeper dive like we did yesterday. Report vaccine lot manager. After our course yesterday, a couple of people cornered me. You're adding the same lot number comes in again, just increase the shipment. You don't need, the only way I would change that in here would be the funding source, right? Because if it's private versus VFC. But continue using, if they're gonna send you ABC 123, use increased shipment and keep going with it. So just, right, that's the only time that you would, if they give you ABC 123 for private and ABC 123 for VFC, that's true. It's all down to the funding source, right? And this is your guys' quick, down and dirty way to see everything. I think there's a pointer on here, isn't there? Which one? Red button? All right. So this is your quick, down and dirty. You guys being the boss, you don't want to go to the report library, go to your vaccine lot manager, and it's going to give you everything you need to know right here. You cannot print it from here. So remember, this is just the down and dirty, quick, let's look, what's going on, why are we at -1, bang, right here. We do give you the magic button right here, open in reports library if you need to print it, to bring it back to the individual to say, hey, I really need your help here, okay? Other helpful reports in the reports library, just a quick reminder, because I know I see some new faces in here, or you guys are just giving me monkey faces in the back. I'm not sure. No, I'm just kidding. Remember, if it's got the PCC logo, that's our stock report. I did throw one example in there. It doesn't have it, which means somebody made a custom one. Just a kind reminder. You know what? We give you unlimited space. Make your job easier. Customize it. Schedule it. Have it automatically run before you get to the office. Have it ready to go for you. Just do these little things. You're like, well, I want to do it at 5:30 in the morning. Guess what? Do it, right? Because you can, okay? Then when you get to work, you go to your saved reports, you print it, you're on with your day, okay? I don't know if anybody needs me to hit on any of the extra, what's on here. We get a lot of overdue vaccine recalls. That's fun. I don't want to go long-winded for you guys, but my favorite time of year, and we're past it right now, is flu number 2s. When everybody's looking for something to do because we're slow during June, Jim, what do we do? Well, remember, we got to give 2 to the first, the kid. They need 2 in their first year of life if they haven't had one. And flu expires on June 30th of every year. So guess what? Hit your recaller, get them back in there, give them number 2. So they only need to get 1 each additional year after that. And my last slide, because you guys are, oh, we're ready for lunch. Emergency plan. I just want to put this in to follow up to, we got 120 minutes. What does that say? 120 minutes? All right. So we have, so continue from yesterday, like I was saying, with your fridges and your freezers. You guys, it's really important. This is money, okay? And a lot of you guys don't have the luxury like we do in Vermont, where VFC, where it says every kid under 18 gets free vaccines, right? Way to go, Vermont. But a lot of you guys are small, and you have to pay for those. So when something goes wrong, your providers get grumpy. But if we all work together, what's your plan when the power goes out? You know, we say, hey, I don't know, because we've never had this problem. You know, what happens when the fridge quits or the freezer quits? You know, you're right. You got to think of that. Think of the life expectancy. If you have a Kenmore, like I said yesterday, Montgomery Wards, nobody knew what that was. A few of us did, but Sears, not many people. So that's why I use Costco now. But if you guys buy those fridge freezers from there, nobody knows how long those are going to last. But if you get, like, say, the best one I like to recommend, which PCC doesn't suggest, but like American Biotech is really good. The AAP does have a fridge freezer policy, and they do recommend some manufacturers there. I kind of worked with them with that, so that, you know, and these companies, when you buy, you're going to be like, oh my God, that fridge is $1,000. Yes, but when you buy that, you say to them, you guarantee me my stock for how many years? Because if anything fails, they're the ones paying for it, right? So just have a backup plan. And is it okay to say, well, it's going to be at Dr. Who's house in their freezer? Well, you know what? You need to make sure you have that temperature stuff set up there ready to go, so that you know when you take it from your office to Dr. Who's house that that freezer is at the right temperature, that fridge is at the right temperature. And one last thing, do you have the correct coolers to transport it in? You can't just throw those in a bag like I did to come through TSA. No, I'm just kidding. But, you know, that doesn't work, right? So you guys have a plan. Be proactive. Vaccines, I have a passion for vaccines, as you probably can tell, you know, and we all do. And like you said, if you need anything, you call PCC, right? Because you guys always do. Like Romney said, we pick up the phone. That's our job. All right, we were going to do a scanner raffle, but guess what? You guys were so eager yesterday that we gave it away yesterday, okay? we were arm wrestling, you know, like Bloom did in their lovely video, to see which course was going to get it, but, you know, we figured the first course because that was, you know, just the way it was. So our takeaways: life cycle of an immunization record. Notice we're changing it. We like, us old dogs call it school forms, because that's what PCC all did, but let's get into that immunization record. You know, reporting tools and best practices. If you ever have questions, what do? Don't call Ghostbusters, that's old, right? You can call PCC. And if you guys have questions, we'll just pass off the mic, you know, so that we can hear us online. Go ahead, Jolie, you got one in the background?
Yeah, on the vaccine report slide, it included a report for patient HPV IMS. Is that something that is new? I do not see that option. That was the customized version, right?
That's Jim's customized version. So if you want it, you know, just reach out to support and tell them to get a hold of me, and I can help you doctor that up. I do have a play database of my own. All right.
Going back to the vaccine lot manager screen where you were saying, you know, if you get a vaccine in, it's the same lot number of what you've had before, just add it to what you have in the inventory, which is what I do in circumstances like that. I've still got 6 of that lot number, 10 came in or whatever, I add that 10 to it. Right. But we may be like a 0 count on a lot number that I have it labeled as depleted, but we get in the shipment 3 weeks later, it's the same lot number, but I create a whole new one instead of adding it to that one, because my question is, if it gets down to like a -2 or 3, you know, they do
Yeah, we gotta
sometimes
figure
because
out
somebody's
what's-
clicking on that lot number.
That's right.
So I go to the report library and print off who got those.
That's right.
Is there a way that if you keep adding to that same lot number, that you can break that down to where I don't have to see who got those vaccines 3 months ago? I just need to see who got them in the past 2 weeks.
And you can do your date range and stuff. Yeah, we can work with you with that. Because when I hit right here, open reports library, that's gonna give you in this date range so that we can see who got that. Like the report, I'll show you after if you'd like.
Okay.
I'll show you, because you're right. It goes down to, hey, everybody that had this lot in the last 15 days, or who's had this lot in the last 2 years.
Right.
So you can shorten that down for you, exactly what you're asking for, okay? But it's okay to hit deplete, you're right, because if that's up to you. It's up to you how you want to control. That's the beauteous thing of PCC.
So I have 2 questions. One of them may have been addressed already. I had to step out. When you're bringing over on those bidirectional states, when you're bringing over vaccines from the state immunization system, with ours, our Hep B default is a non-US Hep B combination vaccine. If the immunization system does not have whether Ingerix or Recombavax was given, it will bring over for us to do the drop down to select which vaccine to use. But the automatic default on that is a non-US combination vaccine. Is there a way to change that default?
Well, if it's a non-US vaccine, I would actually look into the CVX code because
Should be an
non-US.
08.
Well, if it's a non-US vaccine, they have separate
Right.
CVX codes rather.
That's what you want to look for.
So actually, come to the thing because there might be more than one issue, but also the listing, like the order that it comes, that drop down, if you have multiple ones, I believe is the database order. So that's not a order that you can manage, but the non-US HIB entry that you see in that list, I don't believe that should even be there. So we could probably talk about that.
And then the other question that I had, I don't know if everyone's state immunization form from the immunization history screen is different when you print it out. I know ours in Georgia does not populate their expiration date up at the top right corner or place an X to show that they're up to date for school vaccines or 11 and up, whatever. And I've been told by PCC that that's something that we can't really mess with or that y'all cannot
There's
work with.
different ways. Are we recording this, Alex? Oh, okay. No, I just we have ways around that because I have a couple Georgia clients, you know. But you're right. There's new requirements. It's harder to script on those forms for us to give an expiration date, but there is a way to make it happen.
I was going to say, if it's a PDF, we can also add like a question file there, so you can type in the expiration date and have it print. So anything that's not, and we can also place an X in that box on a PDF form too. So if,
But it's not through forms, it's the 3231
Yeah.
from the
Yep.
historical.
it's still a PDF, I believe, we just have it in a different place. So we can alter that PDF on our end and put in a question for you to fill out the date and have it print in that spot.
'Cause
And also the
schools
X.
want the date printed, not handwritten
Uh-huh.
a lot of times.
Right.
Yep.
So we're printing it, handwriting, and then
Oh.
scanning it back to the EHR to save to the portal. Or we're just going straight to the Georgia immunization system at the age of 4 and over. We don't even print off through PCC. And then we're having to sign every one of them and then upload them into the EHR.
Yeah, I'm just thinking though, if you're printing it from the history screen, which it is the history screen, right? It's not the
Immunization
forms
history.
component. The immunization history. So that might be the limitation, because I think that when you run that report or when you print that form, we don't, you know how in the forms component you print a form and it gives you, you can type in a response? Because you're printing it from the history screen, it won't let, I don't think it'll let us actually do that because of that. But if it's a separate form, like if you do part of the form in the immunization history area, and then the form that requires the date, if it's in the forms component, we can do it there. And you'd have to print it in different spaces. But we can't do it on the history screen.
We do. If it was a North Carolina IMS registry as Pentacell, why does it come over to PCC and ask us to choose what we accept?
I would need an example, because if they're saying they sent it over as Pentacell, or if it's coming over as Pentacell.
If it was in the IMS registry as
Pen-
Pentacell, why does it come over to PCC and ask us to choose what we accept?
It doesn't ask you. It bases it by the CVX code. So if they had two entries, a VFC Pentacell and a private Pentacell,